So my name is Lama Al-Aswad. I'm professor of ophthalmology and professor of population health at NYU Langone, NYU Grossman School of Medicine. I am the vice chair for innovations and the director of teleophthalmology, artificial intelligence and innovations, and the director of the ophthalmology innovation fellowship at NYU Langone. I'm interested in innovations in general, and not only that, the cost of healthcare and how innovations potentially can decrease the cost of healthcare over time. Initially, it might be a little bit more expensive, but on the long run, it would decrease the cost of healthcare. Cost effectiveness studies are regarded more superior among health economists and clinicians, as it incorporates quality of life measures and given different treatments, options, and outcomes. So this was a study that we wanted to do as a baseline for our other studies that we're doing on cost effectiveness using cost utility, similar to our new publication that was just published in Ophthalmology Glaucoma and the cost effectiveness analysis of minimally invasive trabecular meshwork stents with cataract surgery. In that, we used a Markov model looking at glaucoma progression through 4 glaucoma states: mild, moderate, advanced, and severe, and for 35 years, taking into consideration even death. And I think that's a better way of evaluating cost effectiveness. For that study, we wanted to just look at it quickly before we run the main studies we're doing. And we just submitted to AGS a similar study for trabectome, for Cahook, and for Zen. So we're using a more sophisticated model, and those are literally what we're publishing on our papers. But that was a first step in looking at cost effectiveness. So in our study, we noticed that the Cahook was the most cost effective. It cost $107 per millimeter of mercury, compared to the iStent of $325, and the trabectome $265, and the Hydrus $250. And it becomes cost effective at 12 years for the Cahook compared, and the trabectome, by the way, compared to the Hydrus and the iStent. That being said, again, I have to allude to the study that was published, which is a more robust study. It shows that the Hydrus and the iStent become cost effective at 5 years, comparing it to medication and cataract surgery alone. So in reality, if anybody wants to take the data into consideration, I would recommend looking at that paper, because it takes cost utility into it, not taking one subset of the outcome of glaucoma surgery, which is IOP. The other study looks at progression of disease over time and quality of life. So that's why I would say that this is a great study that we published, and it was a great abstract for AGS, but it only takes IOP, which I think it's a good way of looking at cost, simple and good way of looking at cost effectiveness, but not the robust way to look at it in general. As you know, the cost of healthcare is exponentially increasing. The population worldwide is increasing. The percentage of people with glaucoma is increasing. And we have limited dollars. The healthcare expenditure is not catching up, and we cannot catch up with that. So that being said, we need to better understand cost, and we need to try to decrease cost in early, similar to screening, or early disease to be able to spend more on severe disease, especially not only blindness or glaucoma. Maybe in the future we would have ways to reverse glaucoma damage, and most probably it's going to be very costly, or different ways of neuroprotection most probably is going to be very costly, or neuroregeneration. So if we can find ways to better understand cost and save at the early stages, we might save a little bit more money for later stages. That being said, in addition to that, I think we now don't treat everybody with glaucoma, as a lot of studies have shown. Approximately 50% of people who have glaucoma don't have glaucoma. So we are not treating everybody that has glaucoma. We need to be able to capture everybody with glaucoma and treat them, and that will increase cost even more. So we have to find ways to save money and offer the best treatment with the best outcome and lower cost. So that's why I'm really interested in that, as I see the future of trying to save money in the early stages because they're not as severe, and finding the better solutions for that. And maybe sometimes surgery might be the better way to treat patients. In our model with the paper we published, actually the model was very sensitive to medication. If they were brand medication, it was not cost effective at all to use medication, to be honest. The surgery was more cost effective. So I think that too has to be taken into consideration when treating patients. I totally think so, in my opinion. This is one, but I have to say one other thing is, what is the surgeon comfortable with too? And the reason I'm saying that, there's shortage of glaucoma specialists in the US and worldwide. So if you have a surgeon that's in a rural area that is comfortable with a certain technique, although it might not be cost effective, but because they're comfortable with that, their outcomes might be better, so their complications might be less, so you will not be spending money on treating complications. So it might be a way of using, so although it's not cost effective, but they're better at it with less complications. So you might want to use that, because over time, treating the complications costs more money too. I think it's necessary for us to investigate cost effectiveness for all kind of treatments, and we need to standardize the methods and how we evaluate cost effectiveness, specifically in glaucoma because of vision and blindness. So I think this is very important for us to try to figure a way of standardizing cost effectiveness studies in glaucoma management.